Hey, get in, fellas. We're going back to therapy. It is Wednesday, February 26th, and as our neurodiversity block continues, we are thrilled to bring on my good pal, Dr. Kylie House. She's a psychiatrist and a psychiatric researcher at the Wholeness Center in Fort Collins, Colorado, to talk about not only as a clinician, but her own personal battle with obsessive compulsive disorder. If you haven't been around for very long in our show, the most important thing I want you to take away today is what is the difference between OCD and OCPD, or obsessive compulsive personality traits. So we're going to give you a little refresher right before the interview with Kylie, because I don't think we dive into it deep enough to help you understand those things and why saying I'm OCD really could be offensive to people who struggle with such a severe disorder. We're going to start with an interesting topic that comes from psychology, social psychology, and sports psychology as fans, and this is the concept of BIRG-ing, basking in reflective glory, versus CORF-ing, cutting off reflected failure. We're not only going to talk about it as sports fans, but as parents, friends, and citizens here in this country. We will wrap up as we do inducting, I believe, the most famous person, the most famous KGB in America with OCD, Howie Mandel, who is an advocate for the condition, a well-known person who suffers with it. So going to be a great show, and let's go. What up, y'all? Excited to introduce a really cool topic that as sports fans, as bros, and if you're just listening as a human, you're going to resonate with this as well. This is a social psychology concept that came out in the 70s called BIRG-ing versus CORF-ing. BIRG is B-I-R-G, and that is basking in reflected glory, versus CORF-ing, cutting off reflected failure. This is really relevant to bros, men in particular, as we have our brains more likely to do this kind of thing than women, research shows. BIRG-ing, basking in reflective glory. The easiest way to think about this is when our team wins a sporting event, we say we played really well. We're not on the team. We don't influence the impact. And yet as people, we really think more we when things are going well. Versus CORF-ing, cutting off reflected failure. When the team stinks, when your team loses, we say those bunch of bums. They need to do this. So even just as simply as the pronouns we use can draw our attention to when we're associating with success versus dissociating ourselves away from unsuccessful constructs. This is important because we see it all over. We see it as parents, we see it as friends, we see it as sports fans. But it's a concept that we'll get more into here and why it's important for us to be paying attention to. A little history on BIRG-ing versus CORF-ing. In 1976, Robert Cialdini, he's a psychologist. He actually went on to write a really famous book a few years later called Influence, the Psychology of Persuasion, that's all over the world as far as self-help books and things that have taken some influence over time. He was at Arizona State in Tempe. He published the 3 football field study. It was the first study that showed this kind of bias in people. The first of the studies showed that students on campus were more likely to wear logos and gear associated with the school after a football team's win. Seems pretty straightforward, and yet this was, new. Anything in psychology was new at one point. And number 2 pointed out that pronouns thing. The second part of that football field study showed the pronouns we use also is based on perceived success versus perceived failure. And specifically, in a bunch of college kids, it was more about your social standing. So if you found a cause that was likely to increase your social standing, you'd say we. Something that might ostracize you or decrease your social standing, you'd say they. Even biology backs this phenomenon. In 1998, there was a study that showed that after sports teams win, men's testosterone levels increase, and after a loss, their testosterone levels decrease. This doesn't seem surprising. I really doubt this is just specific to sports. That's the only studies I could find on it. Maybe political things, maybe other types of wins we have, gambling, I bet would show a lot of similar results to this. So why do we BIRG versus why do we CORF? There's a handful of ways to look at this, and because we're educated listeners of this show, we're going to hit them all. Ludwig Levinson was a big behavioral psychologist. His thoughts on this were, we want to learn and repeat what behaviors work. We've talked about development on this show, and that a pretty strong theory of social development is that we just repeat what other people are doing around us. And so As a youngster, you're going to start to associate, look, if people are doing this, it seems to work for them. The peer pressure of sorts is going to have me do it. And then we cut off reflected failure because there's natural avoidance from doing behaviors that don't work and don't benefit us. Humans don't want to be frustrated. We don't want to be behind. We don't want to be doing things that ostracize us. And so we would not do them. Evolutionarily, as our guy Darwin we just talked about a couple weeks ago, shows that if you associate yourself with success, very much survival of the fittest type stuff, then you have a higher chance of mating. And I guess if you flip that, like, losers, things that you associate yourself with, non-winners that aren't as successful, don't get laid. They don't have offspring. They do not increase their likelihood of passing on their genes. Psychologically or psychodynamically, Freud would think about this as far as increasing your self-esteem and accomplishment, really bolstering the superego in order to keep the ego positive and within itself. So a term of like emotional self-management would be the BIRG-ing situation. And in social psychology, which is really where this construct takes hold, we would be enhancing one's self-image, helping our self-esteem versus protecting one's self-image against negative criticism, which we all do. That's really where the roots of all this is, guys. What are some examples that we do all this in real life? Thinking about the Olympics, right? With nationalism, studies show that we're all more likely to watch obscure sports when our country is participating in them. We thought about this with curling, gymnastics, swimming. The only times people pay attention to those are when it's their country, and more specifically when their country does well in them. Fantasy sports, we do this too. We talk about our own players on our teams. We take on this identity. We identify with them because they help us with our social standing with our friends. Maybe monetary, sports gambling shows a lot of this. When we win the bet versus when they lose the bet, you can see yourself associate with and dissociate against those causes. And this is really expanded outside of sports, guys. Brand allegiance, okay? This is where the source of like the iPhone being the most popular thing and blue bubbles versus green bubbles, people identify with brands that are socially acceptable. We're far more likely to repost Taylor Swift 10,000 times on social media because we know it's going to go well and we know people are going to like it and no one's going to have any problems with it, versus if we were to post something that's maybe a little more vulnerable or maybe associated with not such a common cause. And so that's why people tend to do what's cool, do what's common, is they know that it's going to help their self-esteem and help their self-image in the world. But there's obviously negative to this too, right? When we do the BIRG-ing part of this construct, it has us connected to sports, brands, other types of situations that aren't real, okay? We identify, of course, with our home city, our home state, our home neighborhood, our home country. And we also have to remember that, especially in sports, we are not the ones participating. So it feels good when we do well. It feels bad, as most sports fans here know, when we don't do well. So obviously a big sign of emotional maturity as we grow up and we don't have those big emotional swings versus when our team is doing well versus when they're not. So another risk of this is sports betting, violence in sports fandom. We see this, that people, we call it de-individuation. This is a depersonalization. This is a dissociation type state like we talked about back in the Freud ship block. So the more you become associated with a sports team, your home state, a political party is a great example of this, a religion, it really decreases our own self-awareness and it decreases our own perceived accountability, our own perceived responsibility in certain situations. Kind of increases that mob mentality. It decreases our personal accountability and it decreases our own self-awareness, which is a huge problem out in the world. An example of this is in parenting, all right? When our kid does well, when they get a good grade on a test, whether you know it or not, you associate more with them, right? We put on our car a bumper sticker that says, "My child is an honor student." We put out in the front yard a little football player that says, "Hey, I'm really proud of my kid." We don't do those similar things when our kid is not successful, when they're struggling. We need to make sure that we're continuing to tell our kids that we're proud of them, continuing to tell those people in our life that we are there for them and we care about them, even when they're not, helping our own self-esteem. It's huge as a parent. Your kids' successes and failures are not personal to you. They are a necessary part of your child's maturation process. We think about this thing, what's my takeaway on this? This is a random aside. I just thought it was a really cool phenomenon that was named for all us sports fans about 50 years ago. What do I want you to take away listening to this show? One is that yes, there is a role in our life as humans to be sports fans and in politics and in religion to identify with certain causes, and that we have to also make sure that we stay connected to reality, connected to ourselves as an individual, and avoid that de-individuation. We still have to be able to take accountability for our behavior. We still have to understand what is our own moral code and not let either BIRG-ing or CORF-ing separate us from those things when we get stuck in negative mood states. Finding a healthy balance is the overall statement I'm making here. How can you enjoy sports without it, taking a personal hit, as we know it does with men when their teams are really struggling? As I said, we have to hold ourselves accountable for our own behaviors, and that specifically when you see this stuff out in the world, as I'm sure many of you do all the time, especially as we think of today's political landscape, is that we can validate the emotional experience of others, which is what leads to BIRG-ing and CORF-ing. We do not tolerate bad behavior at the end of the day, because this is exactly what I'm saying, is when we're really extreme on either the left or the right of the political spectrum, religion or non-religion, we tend to act in extreme ways, and we want to make sure that people are sticking to their moral code, which is treat people how you'd want to be treated, treat people how they'd want to be treated, stuff we talked about in the show. All right, so that was fun. Let me know if you thought that was cool or worth anyone's time. And if you've got any examples of it, feel free to reach out on our website, gettingfellspod.com. You can, send us anything you want through the website or reach out to us on the socials as well. So as we look to transition into our interview, again, this neurodiversity block, what is the whole point? Is that I want you understanding the lives of somebody who struggles with a condition that is pretty serious. Way back in episode 8 with Harrison, way back in episodes 15 and 16 with Tarek, we talked about OCD versus OCPD. I want to give you a real quick refresher, and Richie's going to throw up on the board an image that might look familiar to some of you guys from 6 months ago when we did this episode with Harrison during the CBT blocks. Obsessive compulsive disorder is considered an anxiety disorder. It's characterized by intrusive thoughts, those are obsessions, and repetitive behaviors, compulsions that are meant to decrease our anxiety or decrease risk of something happening. OCD, the most common things we think of are germs. We think of repetitions to help keep people safe. So if I do this thing, my mother won't get in a car crash. And it really shows, people have these ego dystonic thoughts. They drive anxiety. They make them feel bad. Talk about that a little more with Kylie here in a second. The thing about OCD is that it goes up and down like a mental health condition, like anxiety or depression. It comes and goes. It's higher and lower throughout our day, throughout our week, throughout our life, versus obsessive compulsive personality traits. If you want a full refresher on this, go back to me and Tarek back in the Freudship block. It's not as severe as a personality disorder, hence I'm saying traits for most people. And this is characterized by a preoccupation for perfectionism and a control over the environment. So again, this is meant to help control the world around you, as personality traits often are, and meant to help feed into perfectionism. So my closet is all color-coded. My house is very, very clean. Right? Most people will say, oh, I'm so OCD, when if you learn here in a few minutes what OCD really is, you're going to see, okay, that's not me. I just like having things clean. I like having control over a situation, knowing what's coming next. That's much more common. And that for people, this is usually pretty standard for them. But this is a lifelong trait. It's usually a personality trait. So it doesn't come and go up and down like OCD. This is something that tends to be pretty stable. So hope that refresher was helpful. Kylie and I talk about this distinction a little bit, but I thought having a refresher at the beginning will help you in this interview and take a lot more out of it and learn more about yourself as well, because people may resonate a little bit with both of these things. They may resonate more with one side or the other. So super excited to have on my friend Kylie. She's great. And we'll be back after the break to start with her. Fellas and others listening, it is our absolute pleasure to introduce my dearest friend out in the Rocky Mountain region, Dr. Kylie House. We were together in residency, one of my first friends I ever made out here in Colorado, and we've stayed very, very close since then. She's a native of Columbia, Illinois, which is a suburb of St. Louis, did her undergrad at the University of Missouri during the Chase Daniel quarterback era. For those sports fans, she got her medical degree from St. Louis University. She works at the Wholeness Center now after finishing training in Fort Collins, Colorado, which is an integrative mental health clinic in Fort Collins. That's about an hour north of Denver. They focus on natural interventions, psychedelic work, and regular psychiatry as well. We're going to have Dr. House on to talk about psychedelics here in a few weeks, but today she's on because she's going to give us an awesome perspective, both patient and practitioner, of suffering with obsessive compulsive disorder. Dr. House, thank you so much for coming on and sharing what is certainly a difficult topic for people.
Certainly. I think thanks for having me on for starters. But to your point, I think it's not one of those flashy ones. It's not one of those that gets a lot of TikTok time. So I'm happy you invited me here so we can give it a little more screen time.
More and more these days, though, I was actually just reading something interesting, and this would be a fun place to start, where like it's gotten popular on the internet for people to be like, I let the intrusive thoughts win, like when they dyed their hair or something or got a piercing. And the OCD community being like, come on, guys, like it's not really like that. So that's a big part of why I'm doing this neurodivergence block, Kylie, because I want to talk about, these conditions and have people really understand what it's like. Our first touch onto OCD came way back when, Kylie, during CBT, when we did challenging fears. We did social anxiety and did fear hierarchies. So we talked about the difference between OCD and OCPD. So Kylie, I just want to start, how do you, both as patient and practitioner, explain OCD in a non-DSM Purple Book way? How would you just describe it to people?
Yeah. I would describe it as, it really consists of two basic things. You have your obsessions and your compulsions. Your obsessions are those intrusive, repetitive, distressing thoughts or images, however it's entering into your brain. And then the compulsions are the things you do to try and mitigate that distress around those thoughts. Yeah.
I asked Kylie to casually explain OCD, and her response was, there's nothing casual about OCD. I was like, well, the language, like less clinical. But we understand, right? Like that the obsessions are often very distressing. Kylie, I've talked about thoughts of OCD being ego dystonic versus ego syntonic thoughts. So thoughts that are distressing to us versus OCPD, where often the thoughts are ego syntonic and much less distressing. And those are ways that we can kind of tease those things out. Flashing back as far as you can remember, like, when did you first realize this was a problem for you?
Gosh, it's so interesting to have an experience and not have a name for it. So I do feel like officially the problem and realizing it was a problem came on when I had a label for it. But there was many years before that was just like, what?
Yeah.
Can't even put a name to it or anything. But looking back in retrospect, I remember being 13 or 14 and not being able to do certain things and having to follow certain rules that didn't make any sense. So an example of that is I just couldn't go down ramps. Like all of a sudden, my brain's just like, nope, you don't do that. You don't go down ramps. You just go downstairs. You can only go downstairs. Ramps are not for you. So
yeah, it's interesting, right? And that's the thing about, again, OCD versus OCPD, obsessive compulsive personality disorder, is like OCD stuff tends to be weird. Not weird as in like it doesn't make a lot of sense, versus organizing our closet or having our desk straightened is something that seems to make sense. So Kylie even pointing that out, right, guys, like, well, why? And it's like, who knows why? There's not a why. So Kylie, it's interesting that, as you were talking about puberty really an onset here, is that a lot of depression and anxiety tends to kick off around puberty. DSM traditionally having been housed with anxiety disorders, can you describe, the feelings that you felt like as a teenager, as you were confused by this? Like, how did it feel more than it thought?
Those dimmer switches in lights, it felt like someone just turned up the lights all the way. Yeah. And so again, it's speaking to that when you don't have words for something, it's this feeling of just undifferentiated sort of, just that, like,
Yeah.
And I'm not screaming because that's probably going to give you some reverb on your recording here. But
you're sounding great.
But yeah, I think it was just all of a sudden, everything's turned up really intensely, and you have these just constant intrusive things happening, and it's overwhelming. I think that's a Sometimes I like to differentiate even between classic worry, where you're kind of ruminating on stuff, and the overwhelming feeling and the constant overwhelm of OCD.
It is tough. I feel like in clinic, it's, I hear kind of racing thoughts, intrusive thoughts, and it's like anxiety, which is anxiety disorders, and OCD, which we just learned, Kylie and I looked it up, that obsessive compulsive disorder is in its own class, obsessive compulsive disorders in the DSM, and then like ADHD too. Right. So
Mm-hmm.
these different kind of disorders that have a lot of overlap, and getting a diagnosis correct is important because treatment is different for all of those things. So, Kylie, after you realized this was a problem in your teen years, like, what did you do next?
Nothing.
Yeah, that's not about right. Yeah,
Yeah.
yeah, sure.
Yeah, yeah. I mean, I do think that it is very helpful to be able to label something and to appreciate that it's a problem in a sense, even though it's clearly overwhelming as high distress. But the thing about me, Stephen, and a lot of people with OCD is that a lot of us don't want to burden others.
Mm.
We don't want to put that responsibility on others. It's our cross to bear. We have the guilt. We have, we have to deal with it. And so a lot of my distress was internalized and I kept it to myself. It wasn't until I went into medical school and I started to realize that is a thing. That's what was going on. Huh. How about that? By then, some of the intensity had died down, and I thought it was a thing of the past.
Mm.
It wasn't until I was in residency did I realize, oh no, I still have OCD. It's just mostly happening inside in my head. I'm not doing a lot of compulsive behaviors, external behaviors. I'm keeping it inside in the mental compulsion side of things.
I would think most of our people, if you haven't taken any time to learn more about OCD, you're going to be thinking like hand washing, tapping, more things that people can note, locking doors, right? Things that people can see. Can you help paint a picture a little bit of what that like mental looked like, or just help, people who might not
Yeah.
see what that is understand it?
So I think to clearly define it, right, a lot of people are thinking about the external behavior compulsions, but there's a lot we can do in our head. So and it's the doing part. Then and we often get that confused with the obsession part, the actual original fears that are bothering us. So mental compulsions can take a wide stretch, a wide variety of different manifestations. But to give you some examples, counting is a classic one. Reversing your thoughts. So if you think a negative thought, you got to think a positive thought, kind of balancing those things out. A lot of preparation for things. So that's one of my favorite things to do in the shower, is start to prep for the rest of the day, and conversations I'm going to have. Let's see, there's more subtle things too, like in hyper awareness OCD. You're just more aware of you're keeping track of your facial expressions, and you're keeping track of where your hands are. You're checking in with your bodily sensations. I mean, these are all things I could be talking to you. You would have no idea that I was doing this.
Benefit from having Kylie on today because, she's done a lot of special training and certifications in OCD to help her understand it and also treat it. Kylie, when did these different like types of OCD, really take hold and become a thing? Because I don't even know how much we learned about it. And I know it's become increasingly known and understood.
That's a good question. To my knowledge, as long as I've been in this business, I've been aware of different themes of OCD, and that's why we call them different themes. So we have our contamination themes, and they're mostly related to the underlying core fear and the obsessional anxiety that's driving it. So we have contamination OCD, we have relationship OCD, we have, gosh, the list goes on. Pedophilia OCD. I mean, I mentioned the hyper awareness OCD, hypermorality OCD, and so on and so forth. I can keep going.
Yeah, so they get categorized really for people, harm OCD, right? Thoughts of hurting yourself or flashes of violence towards others is the main one that I think of because it has such high stakes for people. And Kylie, I wonder if before residency or even as we were, early in our years together, how was this process impacting your day-to-day functioning?
It depended on the theme, and it depended on how much time I had to participate in it. It
Yeah.
depended on the level of anxiety. And I do want to note something that maybe we could talk or speak to a little bit later on, is that the fundamental sort of emotional components of OCD
Hmm.
are more along the lines of uncertainty and disgust. So maybe we can get into that later. But to speak to the functional impact of it, one of the biggest things is that it can really cut into your sleep.
Hmm.
So if I'm trying to get an understanding, and if I have my doctor hat on, I'm trying to get an understanding of how much mental compulsions are cutting into somebody or messing with their life. One of the things I'll ask is how long do you just lay there and try to fall asleep? What's going on? Are you obsessing about things? Are you trying to figure it out in your head? I mean, how much time are you spending just in bed where you should be sleeping and you're mentally compulsing? I would say that the mental compulsions that come with social anxiety can be a separate thing on its own, because people
Yeah.
with social anxiety can have certain compulsions like prepping conversations and reviewing their conversations. But certainly, if you're so busy just thinking about where your eyes are and how loud your heart is and what shape your face is making, it makes it really hard to have a conversation. And
Yeah.
you can kind of come off as a little awkward and a little distracted, and people don't want to give more people anxiety about this, but people can kind of pick up on that.
I think it's interesting, right? As we think about these different neurodivergent conditions, like things that can lead us to be socially anxious, right? It can be insecurity, self-esteem stuff. It can be these types of processes going on, autism and just being aware of the fact that you're not aware as
Mm-hmm.
much, right? So just the fact that social anxiety as an umbrella term, people that can look different for a lot of people. The source and how it looks and how it feels is just something for, our listeners to take away. I know that in clinics, so many patients are resistant to doing the work. And we'll talk about treatment in a little bit, but like sometimes people try and convince me that their OCD is helpful for them. I never know if it's fear of challenging these things or that people find a way to make it work for them. Was it ever like that for you?
I think it's worth touching on that. I think broadly speaking, OCPD, ego syntonic, broadly speaking, OCD, ego dystonic. And of course, in real life, there's usually a mixture of the two going on. I don't know the specific stat on my head, but a lot of people with OCD have some at least traits of OCPD. So everything's, a mixed bag of things. But to your point here, there are certain things that I feel like really were helpful for me in the long run. So not only do I have OCD, but I have the combination of ADHD and OCD. I shouldn't have done as well as I did in school, but the anxiety and the perfectionism and and the need to know in school kind of overpowered any kind of attentional issues I was having in
Hmm.
school. Ended up being a pretty hard worker and pretty obsessive about my need to know. And that persists into today, where I have to give myself a limit on how long I can look something up, because I could spend a whole day just diving into the internet. Thanks, internet, right?
ADHD folks and their timers. The most important tool I can teach somebody is setting
Mm-hmm.
times, breaks, not losing themselves in tasks or, time on non-preferred tasks too. But yeah, Kylie is no stranger to hard work. That is for
Mm-hmm.
sure. As you talked about, Kylie, I like to think about this with ADHD and all these other conditions before there's a label. Do you think it impacted how you viewed yourself or what you thought about yourself before you were able to have a proper label for it?
Great question. I do feel like my ADHD took center stage as far as messing with my self esteem, but maybe more on the social aspect of things. That's where OCD really got in the way and just made me feel like a bit of an alien
Mm-hmm.
overall. So, yes.
And what a social butterfly she's become, people. I mean, just an honor, an honor and a privilege
Mm-hmm.
to be such close pals with Dr. House. A quick aside story that I think Kylie will approve of, pretty PG rated. So, Kylie is not like the rest of my friends from Ohio in that she's unique, does not care about sports, just not into things that even though she's from St. Louis, not really a traditional Midwest gal. So I had a few of my friends visit, my brother David and a good friend Dylan, and they came to visit Kylie's apartment. Her first apartment in Denver was a very, what would you call it?
Bohemian.
Turkish kind of like incense hut. There was only no furniture, mats on the floor. We all sat on pillows and whatnot, tapestries on the wall. And Dylan and David forever will know her as the girl without furniture. You feel okay with that? You have furniture now.
I
Kylie, you
have
feel okay with
furniture
that
now.
label?
Yeah. Yeah, I had to be a little flexible around that. Yeah.
Yes, that's right. Her
Living
husband
with
was the
other
couch
people.
demander. You could probably still go without furniture.
I got some spots, sheepskin rug.
The coolest thing Dr. House has at her house is a table that you lay on
Oh yeah,
and
that's my,
it
my first
plays
list.
music that vibrates in sync to the music when you lay on it. So, Kylie, I know that company's in their early stages. You want to give them a shout out and
Mhm.
talk about how
Yeah.
cool that thing is?
Yeah, shout out to Crescendo Research. So the nice thing about becoming a doctor is that a doctor without kids, I should say, is that you can buy yourself little or big toys.
Yeah. Oh, yeah.
So yeah, I invested in a day bed that can vibrate with the low end frequencies of any kind of music I want to play. And so that kind of speaks to a little bit more on the sensory side of things and sensory processing disorders that can come with a lot of neurodivergent people. But yeah, this thing was created by these two guys and they formed a company called Crescendo Research. So shout out to them. They make my life better.
So, as you move forward, Dr. House, when did you ever get an actual diagnosis and when was treatment able to start for you?
Great question. I think it's worth saying that from onset to symptoms until someone actually gets a diagnosis, the average length of time is about 14 years. So for me, one of my favorite things to do is meet people as a doctor. It's to meet people and do their intake and then realize they've been going through all these different treatments, nothing's working. They have this desperation. And then I'm like, oh, well, this is OCD. And they've never heard of it. And it's been the thing that's been vexing their life. So that's one version of this. My version was a little different, where I just went to medical school and became a psychiatrist. And diagnosed myself. I was like, oh, this is OCD. So yeah, it was a fairly delayed onset of the diagnosis, I'd say. And I had to become a doctor myself to get that diagnosis.
Well, it's not dissimilar, right? I've talked about my story of you're in the Midwest, it's the 90s, early 2000s, like you're just not going to therapy. You're not talking about these things. I'm sure there were kids in my high school class who had those issues and had those problems, but I would not have been able to tell you a single person. If anybody remembers the past, the only reason I ever learned that I was not good with my feelings was from our good friend, Dr. House, calling me out on it early in our friendship. And I will forever owe her and love her for that. And so, Kylie, I think it just speaks to that and to the thought that the idea that you don't know anything outside of your own experience. And so if we aren't able to talk about those things and talk about what's on our mind, what's in our hearts and our souls, how are you going to know what it is outside of just what your day-to-day life looks like? So you wouldn't have even known it was a problem because, you weren't in an environment that allowed you to be sharing, as most Americans are not. Kylie, you said something interesting that I want to follow up on. People having done other types of treatment. When people come to your office and you realize it's OCD, what other types of diagnosis and treatment had they undergone?
I mean, the gamut. There's a lot of misdiagnosis, and so just looking at medications alone, there's people who end up getting diagnosed, for example, with bipolar disorder, and then they're on mood stabilizers, antipsychotics. Not that antipsychotics don't have a place in treatment of OCD, but the crux of treatment is really exposure response prevention. And that's a type of therapy. No one's getting that unless they have been diagnosed with OCD. So, on the therapeutic side, I think one of the most common mistakes I see in clinical practice would be people undergoing EMDR. So their original trigger or whatever kind of prompted them to have heightened anxiety about something that starts to trigger compulsions and so on and so forth. Therapists rationalize, okay, so if we work on the trauma, that initiated this, then the compulsions will go away. And that's not necessarily true. So, really, people need to be getting in and doing some exposure response prevention.
Yeah, when Kylie talks about the original trigger, I mean, we could be using that word trauma because if you've heard of EMDR, and a lot of people, Kylie, have heard of EMDR without a good understanding of what it is. So, eye movement desensitization and reprocessing is a trauma therapy. Kylie, you may have a better way of describing it than I do, but again, using eye movements and visualization to help establish a sense of safety around triggers related to your trauma. And so, is that how you see it, Kylie? Like, okay, it's a good idea because I think at the core, when I think of how I want to treat OCD, it does involve having a better mastery over your anxiety, having a better mastery over, you did a great job talking about the light dimmer, when your symptoms are up and down, but you seem to think or feel like it, I would agree, it misses the mark of what we actually need to be doing with ERP.
Right. So yeah, and of course nothing completely sorts out into one thing or another. I mean, some things can clearly benefit from some trauma processing, but at the end of the day, the stuff that's pretty more classically OCD, you got to expose yourself to the fear, and then you have to not do the compulsions that you're telling yourself is going to reduce the distress or that fear or whatever it is, that feeling that's associated with that obsession.
Dr. House, hold on.
Yes.
Okay, so if I'm thinking, all right, if I don't wash my hands for a certain 30 seconds with 4 pumps of soap, I'm going to get sick. And you don't want me to do that. I'm not going to like that. Why would I want to do that?
Because you have to just trust me, which is a big ask. You have to trust me that when I'm telling you that if you don't do that, if you don't wash your hands, that anxiety wave, it's going to increase and then eventually it will die out. And it is not actually related to the compulsion. So
I
that's
haven't
called
seen
fear
I haven't
extinction.
shared an exposure response prevention curve on this show, Kylie.
Oh,
Gosh, I strongly doubt that I have any kids from ERC in my time there watching this show, but boy, oh boy, did every single kid there get a view of one of these bad boys. So, Kylie, I'm going to share an exposure response prevention curve so people can see exactly what we're talking about here. So, Kylie, you want to walk through this bad boy?
yes, I do. So, right. So you can use this curve for different types of things outside of OCD. So I think it's a great tool to apply to many other things. In the case of OCD, we got this trigger, and this trigger could be something that is just an intrusive thought that pops in your head, like, oh, I'm imagining stabbing my friends, right? Let's say that's it. And then you have the thing that you want to do to try to mitigate the possibility or the sense that you are going to stab your friends. So that would be the compulsion that you're trying to do, right? And I'm telling you, no, don't do that. We're going to let that trigger ride. We're going to note all the OCD thoughts and all the urges that come with that. And if I don't do this, if I don't say the Hail Mary, I'm going to do this. This is going to happen. You notice people's anxiety, or I like to use distress just to be a
Yeah.
little bit more general. And then eventually over time, that distress really does go down. I mean, you don't end up stabbing your friends. In fact, when I'm doing therapy, when I'm doing ERP with someone and they have harm OCD, I mean, one of the things that I feel 100% confident about as someone with OCD, I don't get that often, is I feel totally comfortable with someone holding a knife to my neck. And I'm like, let's do this. I don't think you're going to stab me.
I'm going to unshare the screen, Kylie, because if you were just listening at home, you're looking at a pretty basic XY graph, and when you feel anxious about something, the curve goes up. You have a decision point where it's like, I'm either going to perform the compulsion so that I can avoid or relieve this distress. We talk about avoidance a lot on the show, Kylie. So I know it's not exactly the same in OCD, but the concept of I'm either going to get off this fear ladder that's going up, this train is going up,
Mm-hmm.
and my brain is like, dude, if you don't do this thing or you don't get out of the situation, like with social anxiety, you're going to fucking burst.
Mm-hmm.
So, what ERP is asking us to do, or exposure work in general, is to go up, expose yourself to that anxiety and prove to your brain that you do not have to wash your hands for 30 seconds and 4 times, or else you're going to get COVID or the flu, right? And slowly over time, convince your brain that whatever it is, you can handle it, you can tolerate it, and your brain will not explode.
Yeah, that I think that's the key thing here is that we're trying to increase our tolerance towards any possibility. So as someone who does ERP, I cannot guarantee that someone's not going to get in a terrible car accident and die, or some of these, ill-fated outcomes that are the distressing thoughts. But we're going to try and increase the distress tolerance around those possibilities and realize that the compulsions, you can do them to the moon and back, and really what's happening there is it's intruding into your life, it's taking over your life, and shit happens.
Kylie, ERP is something I certainly welcome people to look more into, exposure response prevention, because not only do we use it for OCD, I ask my patients, again, with eating disorders, with substance use, anything where you are using a behavior to avoid more anxiety or avoid distress, to look at ERP as a framework for living their life. If you have something you're scared of, a very quick example is, let's say you got bit by a dog. Most people can say, well, yeah, you'd probably be scared of dogs. So you start in a very ERP-esque fashion with looking at a picture of a dog, listening to a dog, seeing a dog from across the yard with a fence in between, right? Then you pet a dog with a muzzle, you take off the muzzle, right? So the idea that we build back up, to something we're scared of. ERP with OCD, not usually that straightforward, right, Kylie? Because the things in our head are more complicated often than this dog bit me, ouch, I'm scared. But the idea of taking a challenge and building up and allowing yourself to feel that stress, something I think any of us can find ways to use in our life.
For sure, for sure. Ultimately, it's about doing the thing. And I would make a distinction, just I don't know, maybe it's my preciseness that I have to engage in here. But so there's exposure therapy and there's exposure response prevention. And so all the fear-based stuff, all the anxiety disorders, you do the thing. And the difference with OCD in ERP to treat OCD is that you expose yourself to the thing, and then you don't do the compulsion that is telling you that, like, your brain's telling you that you need to do it.
One, Kylie makes a good point here that I try to bite my tongue around this, and did so with Harrison when we talked about people saying like, oh, I'm so OCD when they mean OCPD, is that this is very distressing for people with moderate or severe cases of OCD. It is terrifying shit. So I don't want to be misspeaking. When I think of that, Kylie, just from a treatment perspective, I think of the response as running away,
Yeah.
avoiding.
Good point.
So you're
Yeah.
preventing, yes, you're being exposed to, and people might think of like a flooding, kind of treatment that does or doesn't help a lot. But it was with my eating disorder kids that I really took this mantra. The response that we're trying to prevent is them just not eating, and therefore continuing to feed into the cycle of their anxiety. So it's not maybe as much of a compulsive behavior, though you and I know how often that OCD and eating disorders tend to overlay with each other. But the response we're preventing is avoiding and bouncing.
Right. I see what you're saying. Yeah. And to your point, there's a lot of avoidance in OCD, and we do count it as a compulsion.
Yeah, you're right. Just bouncing. We talked about, we're talking ERP, which really is the mainstay treatment, and you'd bundle into that because ERP is within cognitive behavioral therapy. So, other things you're teaching are, distress tolerance skills and mindfulness skills to help people tolerate that distress. Because look, you're not going to let them do their compulsions. They're going to freak the fuck out. What about medications, Kylie?
Yeah. So medications play a part. And for some people, how I conceptualize it is that exposure response prevention is kind of the main course of treatment. And so I'm going to give you a general answer here. Of course, there's exceptions to everything, but I think about exposure response prevention, ERP being the main course of treatment, and the medications being a side dish here. Now, for some people with mild OCD, they can get away with just doing medications, and then naturally all those intrusive thoughts and everything just sort of die down. Really, the best outcomes come from the exposure response prevention. And then even better is the combination of the two.
OCD is really, I want, the condition when I talk about treatment for mental health conditions of any kind are not a light switch. People want to be better. And I
Mm-hmm.
ask people to reconstruct, reframe the idea of better as a dimmer switch. I thought that was so nice that you started with that, because OCD is a prime example of, the treatment helps it get better, dimmer switch, and it is considered a chronic condition. So yes, if you're killing life, your obsessions are calm, kind of like your overall stress level. And when things are crazier and more hectic, it's going to get worse. So, the medication, Kylie, at least how I think of it, one, it can take some of the heat off of, if not eliminate the obsessions, but some of the heat off, your response to it, but also allow you to engage in treatment, allow you to engage in
Mm-hmm.
ERP if the thought of doing that is too distressing at this time.
Yeah, it can be a nice appetizer in a sense to
Right.
the
And
main course.
that's the idea of our, getting fellas, we're going to therapy here, right? Is therapy is always going to be, the medications have a role in lifting your floor, calming things down enough to do the things we need to do. Exposures, have tough conversations, go to our shitty jobs, break up with our terrible partners, whatever we need to do in order to improve our lives. The medications are a tool to make that more doable. So,
Mhm.
Kylie, I wonder, how does OCD still go on to impact your day to day?
That's a good question. I mean, like I said before, for me, the OCD is primarily the mental compulsions, right? And they're so subtle. And you start with the anxiety thing, then just and I'm always just picturing myself in the shower here because it's before I've really woke up. It's before I can really direct the mental compulsions, and I'm sitting there washing my hair, and I'll just start, imagining conversations with people, prepping with people. Heck, I was telling this to some people the other day. I had a nightmare where a volcano erupted in Denver.
Hmm.
And because I was in this kind of in between state, I woke up from the nightmare and I stayed up for an hour imagining what I would pack. And it's just like, stop it. Like, I want to go back to
We're a bunch of
sleep.
geologists. We need Randy Marsh here. He's a geologist, right? And Kylie, I want to wrap with the question I'm going to ask everybody during this neurodivergence block is what would you want people, what common misconceptions or what would you want people to know about OCD if they took one thing away from this conversation?
Well, that it's not just washing your hands,
Hmm.
right? That people can have this pure mental compulsion version of OCD and live your life. Don't let the OCD live it for you.
More targeted OCD treatment is available, than there used to be. So if you look up OCD treatment, ERP, those kinds of things, NoCD is an online treatment center that we work with Kylie at Talkiatry, and there's just more and more of it. So please do your research on this. Try and understand, the differences between when you call yourself OCD because you want your hair to look nice versus what Kylie's talking about, which are those crippling levels of intrusive thoughts for people. So just as we look to build empathy on this show and have people understand, Dr. House, we appreciate your time and your authenticity and your vulnerability to help us learn some stuff today. This was actually, I wanted Kylie to do her recording for the psychedelics that she'll come back and talk to us about, as is her whole career. And she said, no, I think it'd be easier to come on and talk about having OCD first. And I was like, really? So everybody get ready for whatever the psychedelic talk is, because apparently Kylie is going to be a real one. It's going to be a real one, harder than talking about the life experience of having OCD. So thanks
Thank
again,
you,
Dr.
Stephen,
House.
Dr. Solomon, Dr. Stephen Solomon.
Both patient and a practitioner, Today's Bromotions Hall of Fame inductee is Howie Mandel, born Howard Michael Mandel, November 29th, 1955, in Toronto, Canada, a renowned comedian, TV personality, actor, producer, and more importantly, I think that he's probably the most famous person we can think of and the biggest advocate for obsessive compulsive disorder, as we talked about on the show today. To give you a little background on Howie, it's a good one. He came up as a really famous comedian. He's talked about having ADHD in addition to OCD, shock and awe, he was initially expelled from college for impersonating a school official and hiring a construction company to build an addition to the school. So ADHD type behavior there too, definitely some impulsivity and a pretty fast moving brain. As we saw, he started his stand-up comedy career in his early 20s, and he had a really famous rise. He was considered like a manic. There was a quote I saw that his performing style was borderline psychotic as he was a young kid and really doing more zany kind of things as he rose through the ranks. His most famous part of his stand-up comedy routine early on is he was famous for taking a latex glove, putting it over his face and blowing it up with his nose until the balloon expanded, the glove expanded on his head until it shot off his head. Unfortunately, medical doctors had to put that to a kibosh because he perforated a sinus. Sinuses are little holes in your skull. You don't want them to be open to the air with perforations. So he had to cut off the latex glove technique. He went on to open for David Letterman. His star rose in he's on the medical drama Saint Elsewhere. He voiced Gizmo in the Gremlins, and he was also multiple characters in the Muppet Babies. I'm assuming, people in my millennial generation will remember Muppet Babies from our childhood. If not, go back. It's worth a whirl. In the 90s, he took another bump up in the world. I'm really sticking with my millennial friends. He created, produced, and voiced Bobby from Bobby's World. Another throwback that if you don't remember from the 90s is certainly worth your time. What we would think of him from nowadays, and from 2005 2009, he hosted Deal or No Deal. And from 2010 until the present, he has been the longest running judge on America's Got Talent. In 2008, he got a Hollywood Walk of Fame star. And around that same time, he was voted on Comedy Central's 100 Best Comedians, number 82 of all time. So why the Bromotions Hall of Fame today? As discussed, he is a famous advocate for OCD and also ADHD. I want to show you an interview from ABC News in 2009 from when Howie was at his peak of Deal or No Deal fame and when he first went public talking about his life with OCD.
It is a crippling and mysterious disease that makes everyday life a minefield for some 5 million Americans. OCD, or obsessive compulsive disorder. And one of those people is superstar comedian Howie Mandel. On stage, he makes millions of people laugh, but off stage, he can't shake hands with them or touch a doorknob or a glass or even be with his own family at times. Here's David Muir.
It's 7 o'clock in the morning, and Howie Mandel arrives at the set of Deal or No Deal.
First trick of the day.
Almost immediately, glimpses of the Howie Mandel that he's kept secret for most of his career.
Handrails are my enemy. I never go near a handrail. I won't open those things. I would never serve myself. I wouldn't touch this because a lot of people have touched that. This is actually my nightmare.
Mandel has obsessive compulsive disorder, OCD.
I love this. Every door should just push out.
His obsession, germs, an obsession made famous with his trademark fist bump.
And what's the difference between shaking the hand and the fist bump?
In my mind, this is a petri dish. Otherwise, I would spend the day as I have in the past in my life in the men's room, rubbing and scrubbing and scalding.
But as we were about to learn, Howie Mandel's OCD goes far beyond that fist bump. Off stage, it is all-consuming.
Oh, look, everything's brand new each day. That's normally how a workstation looks. Look at my stuff. It's all brand new, not touched.
Even Mandel's trademark bald head is this way by choice.
This feels so streamlined and so clean. It just feels cleaner.
Not even 8:30 in the morning, and we've barely scratched the surface. Mandel has written a new book called Here's the Deal, Don't Touch Me, revealing his at times crippling struggle with OCD.
It's uncomfortable, and it's hard, and it's somewhat embarrassing. There were many times when I wanted to back out. I'm not somebody who sits down with strangers as I sit here.
We go way back.
But it's not even you, it's them.
Mandel's fans would never know just how deep it goes. Until now, the audience had only heard this.
Howie Mandel does not shake hands, okay?
Howie
You either
Mandel does
knuckle
not shake
him, you can hug him. You can knuckle him, you just can't shake his hands.
Backstage, it's the rush to the set.
What?
Howie Mandel has been on stage for 30 years now, first making his mark as a manic young comic from Toronto.
What?
There would be more than 20 appearances on The Tonight Show with Johnny Carson.
I've been carrying this for about 2 months now. It's a lucky rabbi's foot. And
See, a lot of folks would think that's what would set off a panic attack, is sitting next to Johnny Carson, your idol.
That's totally different than the fear that OCD injects into my life, which is terror.
Terror, as you heard from Kylie too. I think the kind of anxiety in these situations, it just consumes people. Hence why it's so important for us to be speaking about the differences in that advocacy world. Howie had a great quote about what took him so long to seek help for OCD. And he says this about his childhood. I don't remember a time when I didn't feel there was an issue, but I wasn't diagnosed until adulthood. I've always felt a little bit different, and I always knew I wasn't as comfortable with life as everyone else seemed to be, but I didn't know what I could do about it. When I was a kid, I didn't know anybody who went to a psychiatrist. There was always a stigma attached to mental health issues. I think there still is, but now I'm taking care of myself. And speaking of which, in 2022, Mandel began to partner with a company called NoCD, which is an online mental health care company focusing on increasing access to evidence-based treatment for OCD and related conditions. I'm going to play Howie here with a video sponsorship of him with NoCD. If you're looking for more information, a mental health care company focusing on increasing access to evidence-based treatment for OCD and related conditions. Here's Mandel in an advertisement for NoCD.
I'm a comedian. Apparently, I know what funny is. Funny bought me a house. But I also know what isn't funny. OCD. People throw the term OCD around like it's no big deal, but it's a severe and very common mental health condition that needs specialty treatment. In fact, general therapy isn't just ineffective for OCD, it can actually be harmful. If you or someone you know has reoccurring intrusive fears from OCD, go to nocd.com to get evidence-based treatment.
And of course, if you're a student of the Getting Fells podcast, you know that he's talking about exposure response prevention. Go back to episode 7 with Harrison if you're interested in learning more about exposure response prevention, because as he said, regular type of therapy, implying talk therapy, which can be great for perfectionism type OCPD, is really rough when you're suffering with OCD with intrusive recurring thoughts. You want to make sure you're hitting those with systematic ERP is the best way to hit that. So Howie's a great example of somebody who, even though they struggle with a really serious condition, as we're learning in the neurodiversity block, people can thrive, people can succeed, people can be famous and successful, even while struggling with these conditions. Now, getting help, all the more helpful, all the more important. And we thank Howie for being a real KGB in his efforts to advocate for such a serious condition. So we'll be back to wrap up after the break. All right, let's wrap as we do by citing our sources and our takeaways for the week. Our sources from the BIRG-ing versus CORF-ing, that all came from the American Psychological Association study on BIRG-ing, but there's been a handful of really good studies, as I alluded to, and feel free to check those out. The OCPD versus OCD image came from Very Well Health, a great resource on everything mental health, and Howie's interviews during the BHoF came from ABC News and then NoCD. If you're interested in learning more about OCD treatment or the NoCD company, you can find them at treatmyocd.com. What are our 3 takeaways? 1, BIRG-ing versus CORF-ing. We're human. Everybody does that, okay? We try to associate with successful things, dissociate from things that aren't as successful, from failures. And what's important is stay within ourselves. Balance those forces. Remember, we are still accountable for our actions, and we need to stay within our own moral compass and make sure that we're not letting those types of things, that kind of fanaticism, run away with us as it can. Okay. 2, OCD on the whole is a motherfucker. Okay. Make sure you're using correct language when you're talking about OCD versus OCP traits. That was the number 1 thing we wanted to learn today. And number 3, as Howie taught us, make sure you're getting help as early as possible, okay? Howie struggled with that. Kylie struggled with that. And there's, again, a long wait time between when symptoms first occur and somebody struggles with OCD versus when there first begins a diagnosis and treatment. So if you're worried about something like that, seek professional help, seek professional opinion, and seek treatment. And if you're wondering about how to do that, you're free to reach out on any of our social medias, Getting Fells Pod email. I'd be happy to help people navigate resources if you're interested. All right, y'all, as we would do, let's find ways to be kinder and gentler this week and be good role models in our sphere of influence. And I'll see y'all next week.